How these work, the Cinemet, or carbidopa-levodopa, is basically an ingredient, and it's L-dopa, basically. It becomes decarboxylated dopamine, and then is used as a transmitter released by the presynaptic cell to stimulate the cells that are needed for movement. And it does help. It helps with movement. It also helps with patient survival over the course of 15, 20 years that they'll be dealing with the disease. And this is early studies showing that Cinemet or carbidopa-levodopa definitely improves the patient's life span and their life quality of life. Now, the dopamine agonist is the other big group. Again, when the cells become so deficient in their ability to manufacture dopamine, we depend on direct stimulation of the dopamine 1 and 2 receptor. And that's what dopamine agonists do. And it's a pill. And these are the pills. And there's the little white pills there. And there's a little white pills that look like a star. Okay. So in our algorithm, when we think of patients day to day, we make the diagnosis, and we are not perfect at making that. I think even in the best of hands around the country and around the world, neurologists will misdiagnose probably about 15% of patients. But in the general practice, it can be even more. So, you know, we don't have a perfect, it's not a perfect world, but when we make the diagnosis of Parkinson's disease, we give them the option of no treatment, we give them the option of pharmacologic pill treatment. And some of those pills that I showed you were purportedly neuroprotective. And another concern that we want to think about is how disabled are they? And that's another determination that we make if they need to be treated at all. We talked about those treatments, or sometimes we use both the dopamine agonist and levodopa. And then I'd like to talk about the surgical treatment, because that's an exciting area that I think is a remarkable addition to the patient's armament for treatment. So this is the area, again, depicted in more of a 3D form, where we are aiming to treat with surgery. You can see it's a very small part of the brain. It's very centered. And this is the putamen, and this is the caudate. And between these, the fibers from the cortex go down to the legs and arms and down that way. It's all blocked in together, of course, and it's very close to the eyes, very close to the blood vessels, so it's cram-packed. And this is kind of the slide that we showed before, but I'm showing you the area of the subthalamic nucleus and the substantia nigra area, generally where those two parts live. The substantia nigra is where dopamine is formed, and I showed you those dark cells before. Again, this complex. This is even more complex. I don't think we're going to test you on this, so I don't want to belabor this, but this is what how we understand this, and it's very complex, and it's probably somewhat theoretical, but we went through this in the physiology class with the students. And what it basically is that the globus pallidus tends to inhibit the thalamus. The thalamus is basically a stimulator of the cortex. So if you're inhibiting this, the cortex, let's see, here we are. It's a complex pathway where the cortex stimulates the inhibitor, and if you do that, then you basically take the brakes off the brake. And what happens is that the thalamus wants to stimulate the cortex, and the cortex wants to tell the spinal cord and the arms and legs to do what it needs to do. That's the direct pathway. And the indirect pathway is kind of a counterbalance for that. And it's very complex. So I think what I want to do is show you how we treat this area of the brain. Now this is a picture of the device as we use it now. It's basically a pacemaker that is a battery, and it sends out impulses through a buried wire under the skin which the surgeon has implanted into the basal ganglia area. In this case, for Parkinson's, it's a subthalamic nucleus. And we do that here at the Parkinson's clinic at Cox. We've been around now, actually we celebrated our 10th year. I couldn't believe it, I almost forgot it. But we've been around for 10 years, and we didn't always have the deep brain stimulator program, but probably for the past 8 years we've been managing these cases from the universities, because people go far away to like WashU or KU, and they come back and they have to go back and forth for these adjustments. So we realized there was a need for that, and it was in our area of expertise. But lately, in the last 3 or 4 years, we've been fortunate enough to have very good surgeons here in town who are able to implant this. But this is not necessarily a new treatment in theory, because as early as the 1950s, they were doing surgical destruction of the brain. You've heard of frontal lobotomies. Well, it's not too much different. They go into the thalamus, though, which is down in the deep parts of the brain, instead of in the frontal lobe, and make a little scar and basically interrupt fibers that were not working properly. And you can go to different parts and do what small. They're just small, not so gross as a frontal lobotomy, but they're very specific to a certain part of the brain, like the pallidum. And so but there can be side effects. And of course, putting a lesion in the brain that's permanent, you can't change it. Once you've made it there, it's there to stay, whether bad or good. So came the deep brain stimulator. And this was initially tried out by a French neurosurgeon in Grenoble, Dr. Benabid. And basically, it was to treat the tremor. And by stimulating the thalamus, we're able to kind of jam up the electronic circuits that were firing aberrantly. Well, as we approached into the mid-90s, it became very useful for essential tremor, which is not Parkinson's. And then by about 2001, it became approved for the use of Parkinson's. I'm sorry, 2002, Parkinson's. So, and here we are, nearly a decade later, and there's been over 90,000 patients treated with this around the world. So what it is basically is a frame is placed on the head the day before surgery. This gives landmarks that are fixed. The patient goes to sleep with this. Now we have a little bit more advanced method in that we don't have this big contraption. We have little spikes or little buttons that are implanted there that are metal, and they can be detected by the X-ray machines and MRIs. And we use those as fixed points where then the brain targets are determined. Well, the surgeon makes a cut in the scalp and makes a small burr hole about the size of a dime, and that's what he works through. So it's much like trying to pick a specific seed out of a cantaloupe, basically through a little hole the size of a dime. It's very impressive surgery, but the tools are there. The patient is amazingly maintained awake. They're sedated a little, but they participate in the surgery, and you'll see that on one of the videos. And we want to evaluate if they're having paralysis, if they're having tingling that's undesirable. We may be in the wrong place. But they have to be cooperative. And we have a very narrow area. And remember the area between the thalamus and the globus pallidus? Well, called the internal capsule. Basically, we try to go through that and reach that deep part called the subthalamic nucleus. And what happens is that this electrode has 4 contact points, which allows for just a little bit of error. We may not always get it just right, so maybe the sweet spot will be here or here, and this may be out here, but that's okay. We've got 4 spots.